Welcome to this medicine masterclass in which we will be discussing a case of heart failure. Heart failure is a clinical syndrome that can result from any structural or functional cardiac disorder impairing the ability of the heart to fill with or eject blood. There are a number of signs and symptoms. This may be shortness of breath on exertion or even rest. The patient may complain of fatigue, leg swelling or peripheral edema, orthopnea, that's the inability to lie flat, or paroxysmal nocturnal dyspnea, where the patient wakes up gasping for oxygen or air as fluid accumulates in the lungs and distributes throughout the lung tissue. Let's present a case. Mr. Jones, who presents to clinic with exertional shortness of breath. When you're presenting this case, start by setting the scene. So state that Mr. Jones is a Caucasian man and he's presenting complaint. Explain how the patient was at rest. So in this case, the patient was comfortable, and we note that oxygen was being administered intranasally, and comment on the flow of oxygen, for example, 2 litres per minute. If there's any other medical devices, make a note of them by suggesting, I noted a cannula was in situ in the dorsum of the left hand, and whether or not there's any walking aids which would suggest functional limitation. On inspection of the precordium in lone heart failure, you would not expect any scars. When you palpate the apex beat, you would expect displacement. Usually, the apex beat is in the left midclavicular line, 5th intercostal space. But as the heart fails and the patient develops cardiomegaly as a response to the failure, the apex beat displaces into the left anterior axillary line and can be palpated around the 6th intercostal space. When you auscultate, heart sounds 1 and 2 would be audible, but you may hear a 3rd heart sound and a 4th heart sound resulting in a gallop rhythm. You may also auscultate by basal crepitations in the lungs. Peripherally, the hands may appear cool, and this is due to impaired circulation. The pulse would be regular, 72 beats per minute, for example, but you may notice that there is beat-to-beat variation in the strength of the pulse, and this is described as pulsus alternans. This occurs because as there is increased left ventricular dysfunction, the ejection fraction decreases, resulting in an increased end diastolic volume. That end diastolic volume in the subsequent cycle will increase the myocardial stretch, and through the Frank-Starling mechanism will increase the force of the next contraction, and this cycle then repeats. This ECG strip demonstrates electrical alternance seen in advanced heart failure. Peripherally, you may note that the JVP is elevated and comment on the vertical distance from the sternal angle. Above 3 centimeters is usually pathological. And in heart failure, you'd expect a normal pulsatile waveform, but with distended neck veins. Remember that the JVP has an A wave and a V wave. The A wave corresponds to atrial contraction, and the V wave corresponds to maximal atrial filling. You may be asked to discern the JVP from the carotid. Note that the JVP is readily occludable by digital pressure and so is impalpable, whereas the carotid remains palpable. The JVP is found laterally between the heads of the sternocleidomastoid, whereas the carotid is found medially between the anterior border of the sternocleidomastoid and the larynx. The JVP is affected and drops with inspiration, whereas the carotid does not change. The JVP has a biphasic waveform and the carotid has a monophasic waveform. Peripheral findings will include peripheral edema. If this is found on examination, then comment on the extent, whether it's pedal, that's limited to the feet, ankle edema, mid-shins, knee, thighs, hip. In a male, assess for scrotal edema, and whether the edema extends into the abdominal cavity, the thoracic cavity, or the face. And putting these signs together offer differential diagnoses of heart failure. This may be right, left, or congestive, and systolic or diastolic based on the echocardiographic findings, and also offer other causes of edema such as renal disease and liver disease. And you can explain to the examiner that through a detailed medical history and further clinical examinations, you would be able to distinguish the various differentials. Putting all this together to present a case of heart failure, you could say, Mr. John is a Caucasian man presenting with shortness of breath, comfortable at rest, and 2 litres of oxygen per minute were being administered intranasally. A walking aid was noted by the bedside. I believe that the gentleman has signs consistent with heart failure. On examination of the precordium, the apex beat was displaced, present at the 6th intercostal space left anterior axillary line. A ventricular heave was present. On auscultation, heart sounds 1 and 2, as well as an additional 3 or 4th heart sound or a gallop rhythm was auscultated, and there were no obvious murmurs. I also auscultated bibasal crepitations. The pulse was noted to be regular, pulsus alternans with a rate of 72 beats per minute, no evidence of radial or radiofemoral delay, and there were cool peripheries with a prolonged capillary refill time of 3 to 4 seconds. On examination of the neck, I noticed that the neck veins were distended and the JVP was raised 4 centimeters above the sternal angle, albeit with a normal pulsatile waveform. I also noted that the patient had pitting edema to the mid-shins. And this would lead into a discussion about heart failure. Let's start by discussing the criteria for the diagnosis of heart failure. The Framingham criteria requires 2 major criteria for a positive diagnosis, or 1 major criterion with 2 minor. Major criteria include pulmonary edema, cardiomegaly, positive hepatojugular reflux, neck vein distension, paroxysmal nocturnal dyspnea or orthopnea, pulmonary crepitations, or the presence of a 3rd heart sound, or whether the patient loses weight rapidly in response to diuretic treatment, suggesting that there's an excess of fluid overload. Minor criteria include things such as ankle edema, dyspnea on exertion, hepatomegaly, a nocturnal cough, pleural effusions or tachycardia, relatively non-specific features. Also be aware of the New York Heart Association scale, which has 4 levels. New York Heart Association level 1 suggests that the patient has heart failure but no limitations of their activity. NYHA2 would suggest symptoms with moderate activity, whereas NYHA3 would suggest symptoms come on with minimal exertion, and stage 4 is where the patient has heart failure but is symptomatic at rest. This is used for management as well as prognostication, so as you increase from level 1 through to 4, the annual mortality of patients also increases. You may be asked how you would investigate such patients. You should offer certain blood tests, fluids such as urine, imaging, and we'll talk about these in detail, some special tests associated with heart failure, and H, just to make this mnemonic of B-fish work, means that any blood test or echo that you do should be reviewed in the presence of previous investigations to track disease progression or regression. So let's talk about some of the blood tests that we might do. A full blood count would help us look for signs of anemia or infection, which can precipitate pre-existing heart failure. U's and E's are important, as baseline evaluation of electrolytes is important, particularly when considering the initiation of therapy and drugs used to treat heart failure. You may also detect a chronic hyponatremia in patients with heart failure. LFTs may be deranged if there is hepatic congestion as a result of cardiac failure. A HbA1c would be useful to detect the presence of diabetes mellitus, and a troponin can be used to determine whether an acute decompensation of heart failure is as a result of an acute coronary syndrome. An important test is the BNP, or brain natriuretic peptide, and this is a peptide released from the ventricles, and when the levels climb to more than 400, this is diagnostic and highly suggestive of heart failure, whereas values less than 100 picograms per mil have a very high negative predictive value for heart failure as a cause of dyspnea. It's also important to perform some iron studies. Numerous studies have suggested that correcting iron deficiency anemia improves cardiac function. If you're considering rarer causes of heart failure, perform an autoimmune screen looking for anti-nuclear antibodies, as well as blood tests looking for rheumatological disease. A viral serology or an anti-myosin antibody can be sent if you're thinking about myocarditis as a result precipitating the heart failure. And you can also evaluate for pheochromocytoma if the patient has heart failure in the context of raised blood pressure. Imaging. A plain PA chest radiograph may demonstrate a number of changes, and we use this ABcDE mnemonic. A is for alveolar edema, which you can see here in the imaging presents as bat's wings around the hilar region. B, or curly B lines, curly is eponymous, K-E-R-L-E-Y, and that's peripheral lines that you see as a result of hepatic congestion and interstitial edema. C is cardiomegaly. The radiographic definition is where the cardiothoracic ratio is more than 50%. D is dilated prominent upper lobe vessels. So as fluid accumulates in the lungs in heart failure, there is a reactive hypoxemic pulmonary vasoconstriction in those basal vessels, and that redirects blood flow to the relatively well aerated apices of the lungs. And as the condition advances, you may see effusions developing. An ECG is particularly important to determine an underlying cause, such as whether there's a presence of ischemia or infarction, whether there's any left ventricular hypertrophy or arrhythmias present. And if the patient has a normal sinus rhythm and from the history you believe that the patient's having intermittent arrhythmias, you may want to consider a 24, 72-hour or a 7-day tape or an implantable loop recorder device. Patients may also be exercise tested to see whether or not there's any change in the ECG. But the key investigation that you require is an echocardiogram. This would allow you to determine global left and right ventricular systolic function as well as the ejection fraction, to determine the diastolic left ventricular function, and also to assess the chamber sizes and to detect whether or not there are any regional wall motion abnormalities, which may be as a result of coronary artery disease. And this would also allow you to determine whether there's any valvular dysfunction. More advanced investigations include cardiovascular magnetic resonance imaging. So by using late gadolinium enhancement patterns, this can suggest myocardial infarction or other types of cardiomyopathy. And an angiogram is important if you're thinking about an ischemic etiology. So what are the causes? Ischemic heart disease is a major cause, as is hypertension. Alcohol and drugs can also cause heart failure. Valvular disease, as they progress, can result in heart failure. Long-standing arrhythmias, as well as rarer things such as amyloidosis and connective tissue diseases, can also cause the heart to fail. So how do you classify heart failure? You can classify it as right heart failure, left heart failure, or an acute decompensation or chronic. If you have the combination of right and left heart failure, we classify this as congestive cardiac failure. Right heart failure occurs due to respiratory disease predominantly, which results in chronic increase in pulmonary pressures. So for example, COPD, cor pulmonale, pulmonary hypertension, right valvular disease would result in right heart failure. Left heart failure occurs as a result of myocardial infarction or chronic artery disease. An acute decompensation may result from a cardiac insult such as ischemia and ACS or hypoperfusion, whereas chronic heart failure is a long-term process resulting in cardiac remodeling as a result of the neuroadrenergic drive as well as ischemia. Importantly, it's key to determine whether there is a presence of diastolic heart failure or systolic heart failure or both. Diastolic heart failure is sometimes described as HFpEF, or heart failure with a preserved ejection fraction. And this can occur as a result of hypertension, increased age, diabetes or obesity, and it's usually due to an excessive stiffness of the heart, resulting in an inability of the heart to fill properly rather than its ability to contract. Systolic heart failure, or HFrEF, heart failure with reduced ejection fraction, occurs as a result of valvular disease or structural heart disease, MIs, neuroendocrine activation. HF PEF is where the ejection fraction is more than 50%, and HEF-REF is where the ejection fraction is usually less than 40%. And between these ejection fractions, 41 to 49, we characterize the patient as borderline heart failure with preserved ejection fraction. How do you manage this patient? You should advocate holistic, patient-centered management using a multidisciplinary team. Conservative medical and interventional measures may be required. Conservatively, it's very important to educate the patient, as well as to provide psychological support. Advocate smoking and alcohol cessation, weight loss if indicated, optimize any comorbidities, offer fluid restriction to reduce the stress on the heart. Vaccination may be required, particularly the flu and pneumococcal annual vaccination is recommended, a supervised exercise-based rehabilitation program, and the patient may need to inform the DVLA, particularly if the heart failure is affecting their day-to-day ability or is associated with syncope. If the patient has end-stage heart failure, they should avoid air travel, and be aware that there's a wider implication of this diagnosis, and their sexual activity may also be affected as there's reduced blood flow to the peripheries, including the pudendal arteries. The patient may develop erectile dysfunction, and this may also need to be sensitively addressed. Medically, we can again use an ABcD mnemonic. A would be ACE inhibitors or angiotensin receptor blockers. B is beta blockers. D, diuretics. N, nitrates. And D is digoxin for refractory cases. Now, the ACE inhibitors or the angiotensin receptor blockers should not be used in unevaluated renal failure or patients who have hyperkalemia or pregnancy. Both classes of drugs, ACE inhibitors and angiotensin receptor blockers, through the ELITE 1 and 2 trials have been shown to have similar efficacy, but we start with ACE inhibitors, but if the patient is intolerant as a result of a cough, for example, then we can switch them to angiotensin receptor blockers. Beta blockers such as carvedilol, bisoprolol can reduce mortality, and the US carvedilol trial was a very important trial. Diuretics, there are two key types. The loop diuretics control symptoms, whereas the aldosterone antagonists reduce mortality by reducing the remodeling of the heart. And this was a very important landmark trial called the RAILS trial, published in 1999 in the New England Journal of Medicine. It's important, if you start patients on aldosterone antagonists, to monitor their renal function and their electrolytes, particularly their potassium, very closely. Beta blockers, it's important to recognize that if a patient's already taking beta blockers, you can continue that during an acute process unless they develop bradycardia or heart block. And beta blockers have made a name in heart failure. They were originally contraindicated, but now they've become the mainstay of management, and that's because they facilitate the activation of the sarcoplasmic reticulum, increasing calcium exocytosis and resulting in stronger contraction. Cardiac resynchronization therapy may be required if heart failure is not adequately controlled pharmacologically, and the patient can be offered the implantation of a cardiac rhythm device. These are small battery-powered devices that are implanted under the skin, under the clavicle, and this senses the electrical activity of the heart and aims to synchronize the left and the right ventricle to contract together to optimize the cardiac output. And based on the QRS interval, based on the New York Heart Association classification of the patient, as well as the overall assessment, the patient can be offered an implantable cardiac defibrillator device, and this can improve their quality of life. In end-stage heart failure patients, an MDT decision can be made about the possibility of a cardiac transplant, and this is a very good option in eligible patients, and survival is about 70% at 5 years post-transplant. So in this lecture, we've covered how to present a case of heart failure, key examination questions, the etiology, the classifications, the investigation, the holistic management, and also discussed cardiac resynchronization therapy. Thank you for attending this medicine masterclass.